Good afternoon. Welcome everyone, and thank you for joining us today for our webinar on healthcare reform, charting your course or just drifting along. I'm Dan Voss, Product Manager here at TriTech, and I'm honored to introduce our very respected colleagues and friends at Page, Wolfberg & Worth, Doug Wolfberg and Steve Worth, who most of you, if not all of you, are already familiar with. Doug and Steve are attorneys and founding partners of Page, Wolfberg & Worth, and you can read their full bios on the website if you'd like. Driver error here. Bear with me just a moment. So just a reminder that today's webinar has been approved for one NAAC CEU. The CEU certificate will be included in the follow-up email, along with a copy of the handouts and a link to today's recording. And if you missed what I just said, here's a visual reminder for you. Again, being recorded, the follow-up email after this session will provide you the link to the recording as well as the handouts and the CEU certificate. During our presentation today, we encourage you to ask your questions in the question and answer section of your GoToWebinar dashboard at any time, and we'll get to as many of those questions as we can following the presentation. So without further ado, we'll move on to bring Doug and Steve in for our presentation, Healthcare Reform, Charting Your Course or Just Drifting Along. And we have our the shift there that, that's not to say that that's what's happening to our industry, but if you charge ahead without having a plan, that could be the result. Hey, guys?
Yes, absolutely, Dan. And good afternoon, everyone. And we're glad to be with you this afternoon. And I believe you can see my screen. Is that right?
I see your screen.
Okay, very good. Well, of course, we have the standard legal announcements dealing with copyright and all that sort of thing. We're lawyers, so we have to do that. But we did want to point out one particular thing, and that is that we're here giving you general educational information. We're not giving you formal legal advice or definitive statements of the law, so please don't take these as definitive statements. It's a summary of the materials and the whole area of healthcare reform that we're going to be talking about today. So that's basically it. And we've got a lot of stuff to cover today. My colleague Doug Wolfberg and I are going to trade back and forth a few times because it gets kind of monotonous listening to the same person for a great length of time, so we'll keep it lively in that sense. And just to give you a roadmap of where we're going today, we want to just start a little bit about the challenging environment that we're in today and the latest on the Affordable Care Act. And my goodness, had CNN on in the office just a few minutes ago. There's late breaking news. All sorts of things are happening in the news on the healthcare reform law. And specifically, we want to talk about how the expansion of coverage will affect EMS, your agency, and what it means for you, both as an employer, dealing with the employer mandate, as well as some of the opportunities that might be out there for you in terms of how service is going to be delivered in this new era of healthcare reform. We like to look at things in a positive light wherever possible, but we also want to point out finally some of the obstacles and barriers to making this work and try to help you guide your way through some of these issues so that you can gain the most out of the changes. Well, it certainly is a bit of a stormy sea out there right now. Lots of changes. The Affordable Care Act that went into play in 2010 is now going into full gear. We saw a lot of changes come about with healthcare fraud and abuse law changes, greater enforcement by the government, a lot of things that have been in place for several years. But now we're getting to where the rubber meets the road, and that is where we start getting into the employer mandate, accountable care organizations, the individual mandates to purchase insurance and that sort of thing. And certainly we have a revenue squeeze out there, folks, no doubt about it. The challenges we've seen just in this past year is sequestration. Nobody even knew what that word was until this past year. But basically our good friends in Congress who don't seem to get along, we end up with this mandatory 2% reduction in Medicare. That happened in the spring. A couple years ago, we saw the reduction of fractional mileage. That took out about $80 million out of the program for ambulance. We've seen a reduction in the annual inflation increases. We just got one coming up that's going to just make it to 1%, so that's a good thing coming up in 2014. But we got bonus payments expiring. The temporary bonuses that we've been enjoying here for the last 6-7 years, because Congress has been renewing them every year. Well, look what's happening in Congress right now, folks. I wouldn't hold my breath on that one. So hopefully they'll extend them. But with what's happening right now, it would be a real nice thing if it would happen, but we can't guarantee that for sure. And we saw just this past month a 10% reduction in dialysis transport reimbursement to non-emergency ambulance providers. And then to add insult to injury, we've got MedPAC, the committee that recommends and advises Congress on what to do here in terms of funding, and they're recommending basically not extending those bonus payments, and they're recommending rebalancing the whole fee schedule to put a little more emphasis on emergency, which could be a very good thing for 911 providers, and a little less money toward non-emergency providers. So that's some things that are happening. Also, they're looking at medical necessity and looking at the need to further define that, and we know that's been a problem. So those are some of the squeezes that everybody is faced with these days, and the whole concept of healthcare reform is a shift in the focus from occasions of service or volume of transports or number of treatments provided to the quality of those services and the outcomes of those services. Do these things help people? Do they make them get better? That's what it really comes down to. And that is a positive thing. We all want to have programs and dollars spent toward healthcare that actually make a difference. So we've seen a lot of things happening. The hospital readmission reduction program, Doug's going to spend a little time talking about that and what that's all about. Affordable, accountable care organizations, another way of benefiting perhaps in this era of healthcare reform. Value-based purchasing is another thing that's been around for a while, but greater emphasis on that. And some pilot bundling programs. These are some of the things that we're seeing that are shifting this whole healthcare system from quantity to quality. And now we have this whole Post Affordable Care Act landscape really hitting EMS in two different ways. One, the external change, which is going to deal with how you deliver your services. We're looking at a shift to mobile integrated healthcare, if you will, away from that traditional model of you call, we haul, and we don't get reimbursed unless we do haul you, to you call and we can help you in a variety of ways, maybe, check your medication compliance, maybe help keep you out of the hospital. So a shift away from the traditional notion of transportation-driven EMS to community-based EMS. So that's the big shift, and we're already seeing that in various parts of the country that we're going to talk about those in a few minutes. But then there's the internal change. What impact does this have on you as an employer, providing benefits for your employees? And it does have an impact. Many of you are small employers, your combination departments, if you will. You have volunteers, you have career people, some of you are just career folks. So it's going to hit us in the pocketbook, and it's going to hit employers as well. So you got it looking at it from two different ways. Well, the latest on the Affordable Care Act, the latest news, well, just a few minutes ago, President Obama announced that it's been rough so far, the Obamacare rollout on October 1st with the exchanges. Well, obviously that's quite an understatement, similar to the understatement of Jim Lovell when he said, Houston, we have a problem, when the service module exploded and they barely made it back to Earth. So it is bigger than just a slight little problem here and being a little rough. We've had serious problems with the health exchange website. Very few people have signed up, and because of the pressures that are coming from Republicans as well as Democrats now, he just announced a one-year fix, as it's being described, to allow people to keep their current insurance, because about 30 million people got notices from their health insurer that, hey, this plan doesn't comport with Obamacare, sorry, you can't have it anymore, despite the pledge that you can keep your insurance. So the pressures here, of course, the problem with this announcement is it puts the onus on the insurance companies to extend those plans, and they also have to provide notices and comparisons to the plans that are on the exchanges. So this just happened, folks, in the last hour or so. So that's breaking news. So there is the President succumbing to some pressure there, dealing with all the people that have been cut off from their own plans. So, okay. Also, we saw a few months ago the employer mandate being delayed. That's for those employers with 50 or more full-time equivalent employees. It hasn't, the reporting requirements have been delayed and the penalties. So technically it hasn't been actually delayed. It delays for practical purpose the whole program. So employers will not be mandated to provide health insurance until January 1st, 2015. So we'll talk some more about that. Well, the exchanges are open. The federal exchange, healthcare.gov, is open. We have pretty much the majority of states, at least, have opted to defer to the federal exchange. That's the one that's given everybody the problems now. And apparently what we're finding out is they didn't even beta test the thing before it was launched. So unfortunately, the government predicted that there would be 500,000 people sign up on these exchanges in the month of October. Well, the numbers are pretty dismal. On the federal exchange, only 27,000 people have signed up. It's just reported today. Heck, the state of California's state exchange actually surpassed that. They have 35,000 people signed up, and about 70,000 to 80,000 in the states have signed up. So we're talking maybe 100 or 110,000 that have signed up total when they were predicting 500,000. So we're well below the woeful estimates there. And that's important to understand, because the whole premise of paying for this Obamacare is that you're going to get young people who are going to sign up on these state exchanges who may not need health care, that are going to help basically underwrite the costs of providing insurance to others who really do need it. And that's going to create some serious problems. And so anyway, that's the gist of it today. We have the American Health Benefit Exchange for individuals. That's what we're talking about right now. And then there's a small business health options program that allows states to set up exchanges for small employers with up to 100 employees. We think these things are going to take off. There's a number of states that are doing that now, and that's a good thing. That's going to allow small employers, like many EMS agencies, to, you know, shop around and have an easy one-stop way of comparing plans and so forth. Hopefully the states that implement those will beta test the website first to make sure that it works, so that people will have the opportunity to take advantage of that. So the open enrollment began October 1st, 2013 for those individuals interested in signing up for health insurance, and it was launched despite, you know, the serious problems. And, you know, you could just have to click on the TV or check your news website to see all these kinds of headlines, and unfortunately these are the things that you know, are giving it a really, really bad rap right now. So, okay, the individual mandate penalty slightly delayed. They issued some advice saying that no individual mandate penalties for those who enroll in the marketplace prior to close of the open enrollment period of March 31st, 2014. So they're giving people a break because of some of the delays that are happening as a result of the website. They're also saying that the out-of-pocket expense cost caps have been delayed. So the Affordable Care Act basically capped the amount of out-of-pocket expenses that individuals would have to pay for their deductibles and co-insurance, co-payments, etc., to $6,350. That was the max you'd be stuck with as an individual. But that's been delayed to January 1st, 2015. I think that probably benefits the insurance companies more than anybody else. But basically, these caps will mean ultimately that individuals will pay less out of pocket. So I'm going to hand it over to Doug now. He's going to cover how the Affordable Care Act coverage expansion will affect EMS in more detail. So, Doug.
Thanks, Steve. Good afternoon, everybody. It's a pleasure to be here with you. Also like to thank TriTech for partnering with PWW on today's webinar. We appreciate that. So let me jump in and talk about how the Affordable Care Act expansion coverage is going to affect EMS, and sort of start to take a look at how we're going to fit into this post-reform healthcare environment. Now, The Affordable Care Act's really central aims are to increase the availability and the affordability of health care coverage. And the three primary ways that the Act does that are through the individual mandate, the employer mandate, and the expansion of Medicaid. And we'll talk about those in turn. The individual mandate simply means that most individuals, U.S. citizens and legal residents, are going to be required to have a health coverage in 2014 and beyond, and those health plans must meet certain minimum essential benefit requirements. And this is the thing that Steve mentioned, where just in the last hour the President came out and said through administrative rule as opposed to legislation, they're going to extend sort of the grace period for these non-qualifying plans for another year. This goes back to the President's repeated promises of, if you like your plan, you can keep it, which, as the media has pointed out, has not really turned out to be the case. But and if individuals don't have minimum essential coverage, there will be certain penalties that they will pay on through their tax returns as enforced by the IRS. There are some exemptions, as you can see here on this slide, but most individuals will be subject to the individual mandate. The second way that coverage will be expanded under the Act is through the employer mandate, starting in now 2015 instead of 2014. So-called large employers, and we'll tell you how that's calculated a little bit later, will be required to offer full-time employees and their dependents the opportunity to enroll in coverage. And we'll get into some more specifics about that later. The third way is through the expansion of Medicaid. Now, this was one of the real centerpieces of the Affordable Care Act, but you might remember that back last spring when the U.S. Supreme Court ruled on the Affordable Care Act, one of the pieces that they struck down was the requirement that states expand Medicaid or lose all of their federal match on their Medicaid program. The Supreme Court basically ruled that that was really not a choice for the states. It was coercive, and it violated principles of federalism, where the federal government and the state governments sort of have their, their respective areas of legislation. So the Medicaid expansion is now voluntary, which means some states are deciding to expand Medicaid to cover people up to 133% of the federal poverty limit. That's what FPL on this slide means. And some states have decided not to expand Medicaid. And again, even though we don't get into the politics of it and we don't take a position politically, generally the states that have decided to expand Medicaid are democratically controlled states, and the states that have decided not to expand Medicaid are Republican controlled. And the federal government will pay most of that cost of the expansion of Medicaid. Initially, they'll pay all of it, and then that'll go on a sliding scale down to about 90% of those expansion costs in the year 2020. Now, regular Medicaid, just the people who are already on it, not the expanded part of Medicaid, is basically 50-50 between the state and the feds. So this 100%, 95, 94, 93, and 90% would be the federal share of the new coverage of Medicaid, the expansion part of it. And this is a chart on where the states stand on Medicaid expansion. Again, not all states have decided. Some states are looking at alternative models, and some states are jumping in with the expansion. Now, as an employer, if you have more than the required number of employees, and we'll get into all that a little bit later, you're affected as an employer, but you're also affected as a provider. We're going to, we should theoretically see more individuals who come into insurance coverage. So we hopefully will move a chunk of our payer mix from self-pay or no pay to having some coverage, whether that is through a health plan or through expanded Medicaid. We may be dealing with different payers, and hopefully we'll see a reduction in the amount of self-pay or no-pay accounts, which we hope will be a net gain for providers. So the first question is obviously whether or not your state is participating in Medicaid expansion. And if it does, then that should increase the number of people who at least have some coverage. Now, as many, if not most of you listening already know, being on Medicaid doesn't necessarily mean that the Medicaid program is going to pay all that much money for ambulance services. In just about every state, Medicaid reimbursement is far less than Medicare, and we know from federal studies that Medicare is generally less than your cost. So Medicaid is probably way less than your cost. But again, as compared to not having any reimbursement for some of these patients, we may at least be seeing a net positive there. As an employer, again, if you're a small employer and you don't come under the mandatory rule, it will have little effect as an employer, but large employers certainly will be subject to that mandate. So let's take a closer look at that. Large employers must offer full-time employees and their dependents the opportunity to enroll in a health plan that, again, meets that requirement of minimum essential coverage that is affordable, and there's a definition of what affordable means, and provides certain minimum value. Plans must be offered to full-time employees, to dependents. That's now up to age 26. That is one of the provisions of Obamacare that is already in effect, where kids can stay on their parents' plan until they reach the age of 26, and does not include either part-time employees or spouse coverage. Even though many, let me go back for a second, even though many employers do offer coverage for families, spouses, etc., that's not part of the mandate. The employee's required contribution must be no more than 9.5% of the employee's annual household income. That's how the Act defines what coverage is deemed to be affordable. And there are some proposed regulations that would deal with safe harbors for household income and that kind of thing, which gets a little bit more technical. The employer health insurance must pay for at least 60% of the total cost of covered health services. So in other words, this puts at least some cap on the amount of co-payments or deductibles that the plans can charge. The out-of-pocket expenses have to be capped at a certain percentage. Now, the employers that are covered under the Act are employers that are the so-called large employers that have 50 or more full-time employees during the preceding calendar year. And that includes not only full-time employees, but what are called full-time equivalent employees. And this is this slide that we have up now is an area where some folks have really gotten into some confusion over the Affordable Care Act. We know that for other laws, like for the Fair Labor Standards Act and for overtime purposes, full-time is considered 40 hours before an employer is required to pay overtime. Please note that that definition of full-time under the Fair Labor Standards Act does not apply to the Affordable Care Act. Those are two separate, different laws that have different definitions of who's considered to be a full-time employee. Under the Affordable Care Act, they count employees if they work 30 or more hours per week. And this is one of the things that you've heard some of the talking heads on cable news say, that one of the unintended consequences of the Affordable Care Act is that some employers are reducing the work hours of some employees so they can bring their organizations or their companies under the mandate of the 50 employees. So 30 hours essentially, and there's a formula for it, but basically it is a 30-hour rule for full-time status under the Affordable Care Act. And this slide talks about how that's generally calculated. And employers, like individuals, are subject to penalties if they don't offer health coverage, if they offer health coverage that does not meet the minimum value criteria that we talked about, so too much, employee contribution for out-of-pocket non-covered services, or third, they can be penalized if they offer coverage, but it's not affordable. The coverage is too extravagant, it's too unaffordable. Employees have to spend too much of their income on purchasing this coverage through their employers, and then that would also be one way that employers could get penalized. Okay, just again moving on here. Credits are generally only available when an employer coverage is not offered or it's unaffordable or doesn't provide minimum value. Again, that's the criteria for penalties. So remember, the employer mandate under the Affordable Care Act applies to so-called large employers with 50 or more full-time equivalent employees. Small employers, people who come under that threshold, and please, just in the interest of time, please remember we're just giving you a very basic overview. The calculation of whether or not you are covered and subject to the employer mandate, if you're on that threshold and you're close, that's something you're going to want to review with your company's legal counsel. But again, if you're a small employer, fewer than 50 full-time equivalent employees, you have no legal obligation to offer health insurance. You certainly may do that, but the employer mandate wouldn't apply to you. It applies only to full-time employees and their dependents, and you have to offer the coverage that's affordable and meets minimum value. Again, if the employee doesn't accept it, they can go out to the exchange, because remember, they're still subject to the individual mandate. All right, now I'm going to turn it back to Steve, and he's going to talk about an issue that's really been gaining a lot of attention, and that is whether or not the Affordable Care Act applies to volunteers. And we know many of you listening have volunteer agencies, so we want to spend a few minutes talking about that. Steve?
Great, thanks, Doug. Well, this is the controversial aspect of, well, there's a lot of controversial aspects of this thing, but one that strikes to the heart of fire and EMS agencies is, what about volunteers? How do they play into the picture here under the employer mandate? And it really comes down to two questions. Do they and their hours count for determining whether the employer is a large employer? And then, do employers have to provide health coverage to those quote-unquote full-time volunteers who average 30 or more hours per week? And the crux of the problem stems from the fact that, well, here we go, the IRS is running this thing, folks. They're the ones dealing with the penalties and the collection and all that. And you know, when the IRS is involved, they see, you know, they see income as from any source derived, and they're looking at issues in terms of, you know, they want to collect taxes as much as possible. But they also issued proposed regulations in January to define what an employee is, basically, under the health care coverage under the Affordable Care Act. And basically it comes down to a simple definition that it's an employee is an individual who's an employee under the common law standard. Now, the problem with the common law standard is it focuses on the right to control and direct the individual who performs the service. It has nothing to do with compensation. In other words, the common law standard of employer and employee is, hey, if I can control, if I have the authority to control what you do and tell you what to do and direct your activities, that's all you need for you to be an employee. I don't have to pay anything, okay? That's the common law standard, and that's the problem here. There's no mention of compensation requirements, cash, any in-kind, anything, okay? And basically the employer just needs to have the right to control that individual who could, think about it, could be a volunteer, who could be an employee under this proposed definition as to how they would interpret this thing. So when you look at fire and EMS agencies around the country, yeah, we're sort of paramilitary organizations. Yeah, we have a chain of command. We direct and control the manner in which volunteer firefighters and EMS personnel perform their services, okay? So now, if that's the case, if this common law definition ends up being the rule of the land here, then you get into questions like, okay, well, what hours count? Is it actual firefighting duties at an accident scene? Do you count training activities? Do you count fundraising, on-call hours where you're sitting at home waiting to be called in versus duty time where you sign up for a shift and you're hanging around the station, cleanup activities? All these are very unanswered questions, and it raises a specter, if you will, over the whole employer mandate for EMS agencies, particularly those that are combination departments. And there are quite a few of them out there. So essentially, as it stands now, folks, this proposed rule may result in volunteers being treated as employees for the purposes of determining whether that EMS agency is a large employer, and, you know, the requirement to offer health care coverage to those volunteers/employees who average 30+ hours per week. And think about it. There's a lot of agencies we deal with as clients that might have, you know, 10 or 12 full-timers, but have maybe 30, 40, 50 volunteers who work, you know, who are actually doing the services of the organization as volunteers, and they're not getting paid anything. So that's an issue. So stay tuned to this. The International Association of Fire Chiefs, our friend Bill Metcalf, the new president of that organization, has been outspoken on this. Other agencies, other organizations are stepping up to the plate here and starting to question this. The IFC wrote a very good letter to the IRS commissioner saying, hey, make sure that when you finalize these regulations, there's a specific exclusion that says volunteers are not going to be considered employees for this insurance mandate and employer health care coverage. So stay tuned, see what's going on, you know, speak out about this. Talk to your Congress people and say, hey, look, take a look at those regulations that the IRS passed January 2nd, 2013 in volume 78, number 1 of the Federal Register. That's where they were proposed. So now's the time to get active about this to make sure that we don't get roped into this thing. So charting your course, start looking at this mandate issue now, as we just suggested. Don't wait until January 1st of 2015. Start thinking about it. You know, what do you currently offer? Probably most of you already offer a plan. Does it meet the requirements? Consider making appropriate adjustments in terms of staffing, perhaps. Consider new options. You know, we look at healthcare every year here within our organization. Every employer needs to look at healthcare on a year-to-year basis. Do an annual review of your plan. Communicate with your staff. Let them know what it costs. Let them know the options, and let them know the challenges that you have as an employer, because they need to be brought into as part of the whole process here. The days of employers simply just providing insurance as a given benefit are over. And lots of changes here with you know, healthcare reform. You know, in fact, one of the aspects of this is that a lot of smaller employers may end up simply giving employees an allowance that would allow them to go out and buy insurance on the exchange. So we're going to see more of that. We're going to see more of these employer exchanges where small employers are going to be able to shop and try to get the best value plans. So, okay, EMS opportunities in the post-reform healthcare system. We have accountable care organizations. You've heard a lot about that. These are groups that coordinate care for a bunch of Medicare beneficiaries. We as EMS agencies cannot start one, but we can be part of one. We can contract with one. Healthcare systems are the ones that are starting these things. Physicians are starting them. They're allowed to start them. And then, of course, they can contract with various service providers, such as EMS and ambulance providers. You want to get in the door early. You want to make sure that you talk to the folks involved with these ACOs to show them where you can fit in and where you can help, and ultimately, perhaps, where you can contract with them to provide service for those Medicare beneficiaries. So basically, you'll still get reimbursed in accordance with standard fee-for-service reimbursement schedule, but what the accountable care organizations will do is they'll share in the savings. There's incentives here by agreement between the ACO and the government and Medicare to share savings for efficiency, and there's also shared risks. So at the end of the year, these ACOs will be evaluated and may get an incentive payment based on their efficiencies, share in the savings of the cost of providing health care to those beneficiaries who are part of that ACO. And on the other hand, you could also have to compensate CMS for some of the losses as well. So they're going to look at that on a year-to-year basis, and basically that's what that slide's all about. Bottom line with this is you really need to get a seat at the table. You know, it's the holiday season and it's turkey time. You know, you don't have to be the big player at the big table. You don't have to be the adult at the adult table. You can be the kid at the kiddie table, and bottom line is you still get to eat the turkey. So certainly we may not be the major players in the ACO, but we are an essential aspect of that, and we can certainly take advantage of some of the reimbursement opportunities that might be available through those ACOs. So if you haven't talked to your hospital administrators and ACO folks in your community, now is the time to start doing that. So along the lines of some of the EMS-related activities, I'm going to toss it back to Doug to talk about community paramedicine.
Okay, thanks again, Steve. So let me talk now for a few minutes about, you know, this whole trend of community paramedicine. Folks have heard a lot about this, but we want to talk about now a concrete area. We want to sort of drill down to a specific area in which EMS agencies can really sort of financially start to capitalize on some of these ACA issues. And one of those areas is sort of like somebody else's misfortune can be our potential gain. And this is true with what's called the Hospital Readmission Reduction Program. The Affordable Care Act penalizes hospitals for excess readmission rates for certain conditions like congestive heart failure, pneumonia, and acute MI. Those are the initial three conditions, although that list will be expanded, probably like the hip replacements and maybe diabetes, stuff like that in coming years. So right now, if a patient is on Medicare and they're discharged from that hospital, from an acute care hospital, and they're readmitted within 30 days with those conditions, those specified three conditions that are on the list right now, those hospitals are going to get penalized up to 3% of their Medicare reimbursement. Some of those penalties are well into six figures. Some are approaching $1 million. So What that is a pool of money that hospitals would probably be willing to take some of that. If I can avoid $1 million in fines and pay somebody $500,000 to help me do that, it's certainly a worthwhile investment. So that's the idea behind it. And this is an opportunity where community paramedicine comes in. Community paramedicine is an emerging healthcare delivery model that involves the use of specially trained EMS providers, community paramedics or community paramedicine providers, who have an expanded role in the healthcare system. Now, we've seen variations of this. This is in some sense sort of a new wrapper on an old can of beans, if I may use that analogy, because we've looked at expanded scope projects in other areas of the country where medics have been trained to do additional things outside of the hospital. The buzz term in this day and age now under healthcare reform is community paramedicine, but it really at the end of the day is the same idea. It's training paramedics to do things above and beyond what they can do now. And in this particular setting, it would be to deploy them out into the community, going into people's homes and reaching people in the community, not necessarily loading those folks up in an ambulance and transporting them to a hospital. So in a sense, it expands the reach of primary care and public health by using these community-trained paramedics to do certain procedures that are in these expanded scope skill sets and treat these and care for these patients at home or in other settings outside of the hospitals. You know, things like administering immunizations and antibiotic drips and talking to the patient about their care plan, making sure they're keeping their appointments, they're getting their prescriptions refilled, things that start to go more into the realm of primary care. This can increase patient access to this kind of primary care and preventative care, provide wellness interventions within the home care model, keep these patients out of emergency departments, keep them out of beds and being admitted to the hospital, and hopefully saving dollars while improving patient outcomes. So these kinds of services that we see community paramedicine programs providing include things like home assessments, resource need assessments, home safety assessments, or patients at risk of fall. Are they managing their health care? Are they, you know, if they've got a certain condition, are they doing the things that they're supposed to do to treat their conditions? Are they avoiding certain foods? Are they refilling their medications? Are they keeping their doctor's appointments? The things that can help keep these folks out of the hospital. Supportive care and their caregivers and family members. Again, the post-discharge services, which we'll talk more about here in a couple of minutes, and medication compliance, things along those lines. Again, the goal here is to deliver these services in more efficient care settings and avoid or reduce the number of times that patients seek care in the more costly settings, emergency rooms, clinics, etc. So this is where EMS agencies who expand into this idea of community paramedicine or mobile health care can really leverage those out-of-hospital services that we already provide. We do out-of-hospital. That's what we are. So if we can leverage those resources through additional training, additional capabilities to get out there and work in the community and help prevent these readmissions, help keep people out of the more expensive care settings, there are people who are going to be willing to pay EMS agencies for those services. Hospitals don't want these patients readmitted because they'll get penalized financially. Health plans certainly may want to keep these folks from utilizing more expensive services. So this is, again, where EMS can play a key role. And, of course, this also goes hand in hand with the fact that federal and state governments are looking at ways to reduce their health care costs across the board. So there is a building incentive for these agencies to be receptive to new healthcare delivery models that reduce costs, to award grants. We've seen grants for demonstration projects and pilot projects to implement these kinds of community-based paramedicine programs. So let's take a look at some of these obstacles and how we can hopefully chart the course around some of those obstacles. First, whenever we talk about expanding the scope of paramedics or EMTs, primarily paramedics is where all this talk has been, under state law, we've got to look at what our State EMS Act says that paramedics can and cannot do. To be able to expand their scope of practice in most states would require changes either to legislation or to regulations. So many folks are going to really have to mobilize at the state level to be able to allow paramedics to take on additional responsibilities. Secondly is, like it or not, EMS is generally reimbursed as a transport-based commodity. That means the financial incentive that's woven into the system right now is to transport patients. But the problem is when we transport patients to facilities, we're going to be generating health care bills that are 10 times what the ambulance bill was because of the cost of services inside of a hospital. So we have to make the case to Medicare, to states, to insurance companies, and other payers that there is value in paying EMS agencies to do things other than transport. Let us show you how we can help keep your insured population healthier without having to take them to the hospital. And there is a financial value in you paying us to do that. That's the argument we have to make. So far, one state, Minnesota, has put into place a state Medicaid reimbursement model for community paramedicine, but again, that has not yet, caught on among other states and other payers. We're going to be in turf battles, folks. 20, 30 years ago, the big competition in our industry was public versus private. Fire-based EMS versus commercial services, hospitals versus nonprofit, ambulance companies. Those were the old battle lines. The new turf battles, as we get into moving EMS into community paramedic settings, home health, and those issues, it's not going to be public versus private, although that will still happen. It's going to be EMS versus nursing agencies, home health companies. Those are the new competitors that are going out there and providing these services. And if we don't mobilize, and we're well positioned to do that kind of thing, then somebody else is going to eat our lunch. Now we have public and patient acceptance. People see ambulances and they think emergencies and somebody's hurt. We're starting to get the public to see us differently in terms of what kinds of care we provide is another obstacle. And then there are some legal issues like the anti-kickback statute, and we'll talk about that in a moment. Scope of practice, protocols that we have to deal with, rigid medical command and online control issues are all things that have to be addressed at the state level. So at the state level, folks are going to have to get active in their state ambulance associations and their state level organizations to really help make the case that expansion of that role is important to help meet the needs of the community. And again, we've also got to try to crack the nut at the Medicare level, because Medicare, is strictly a transport-based reimbursement model. The Affordable Care Act definitely encourages new models to improve outcomes and efficiency of the healthcare system, and this is where the community paramedicine programs can really tie in. We talked about the turf battles, so we'll kind of move on from that. But you want to get your agency out in front of this so you can have a seat at the table, meeting with your accountable care organizations that are established by your hospitals and by your physician groups, etc., demonstrating how EMS can help those other providers, and not, you're not cutting into their piece of the pie, you're trying to help them financially as well as serve patient care. When it comes to public acceptance, again, that is a public education issue, and that will come with time. We are a relative newcomer, and we have to face that. Hospitals have been around for a long time. Really, it's only the last 30 or 40 years that folks have become a lot more familiar with and comfortable with what EMS does. The public, unfortunately, for better or for worse, largely sees what we do in EMS as a ride to the hospital. So that's something we have to overcome. Okay, so public education, we talked about that, partnering with other providers, etc. And look, we're not just a bunch of Johnny-come-latelys, even though we're the newer kid on the block. EMS is protocol-driven, rooted in medical practice, evidence-based healthcare, and these are the kinds of things that the public and other medical providers need to know. Now, let's talk for a few minutes about some of the compliance and anti-kickback statute risks. When we talk about these partnerships with hospitals and with ACOs and other healthcare agencies, there is always a cross-referral relationship. If we're going to go out and help patients avoid hospital readmissions, and if we get paid by a hospital to do that, well, we also sometimes take patients to that hospital. We're a referral source to them. They may be a referral source to us. If they have a patient who needs transported home or to a nursing home or to another hospital, we may be providing that service. We're their referral source. They're our referral source. That means any of these arrangements that you enter into have to be compliant with the anti-kickback statute. Now, luckily, back in August, the first of its kind advisory opinion was released by the Office of Inspector General. It's called Advisory Opinion 13-10, and it was not related to ambulance or EMS agencies, but it did deal with contracting for services under this hospital readmission reduction program to help keep patients from being readmitted to a hospital. Now, in that advisory opinion, the company that was providing these community services was a company that was a wholly owned subsidiary of a drug company. And they would send people out to help patients coordinate their care, keep their appointments, refill their prescriptions, follow their discharge plans, and that kind of stuff. When a patient would be discharged from a hospital, if that patient elected to get these post-discharge services, the nurse would upload their information to a software program. This company would send out a patient liaison to remind patients of their appointments, help arrange their transportation, remind the patients to refill their prescriptions. And remember, because this company in this particular advisory opinion was a company owned by a pharmaceutical manufacturer, that's where the anti-kickback statute can come in. If these guys are, paid to help patients refill their prescriptions, obviously that results in referrals to this pharmaceutical company. Now, sometimes the liaisons may determine these patients need additional care, so they'll refer those patients to providers that the patients have designated in their records. So the OIG concluded that even though this proposed arrangement could potentially generate prohibited remuneration, that would be something like a financial incentive under the anti-kickback statute, the OIG would not impose sanctions in connection with that arrangement. So this looks like bureaucratic legalese on the slide, but what it is the OIG's way of saying we approve this arrangement. The OIG decided this for several reasons. First, they said this kind of program does not increase health care costs. It encourages appropriate utilization. Secondly, they didn't think that it would interfere with clinical decision-making because it would only apply certain conditions. Third, they noted that there were safeguards built into the program. It wasn't just a way to boost drug sales, for example, for this drug company. Fourth, the arrangement would not result in unlikely patient steering because the providers who would get these referrals were ones who were designated by the patient. So even though this was not an EMS-specific advisory opinion, it really does provide a blueprint on what EMS agencies could and should be doing. And we're also seeing other agencies who are now doing this. So the fact that somebody already went and requested this advisory opinion and had it issued, advisory opinions take like a year to come out from the OIG. So there are folks who are well ahead of us, well ahead of EMS in putting these services out there. So think about it. EMS is well positioned to provide many of these types of services. We have built-in transportation networks. We've got medically trained folks who can spot these conditions that may require follow-up, monitoring compliance with medications, helping to administer medications, educating patients. These are things that fall all within the core competencies of most EMS agencies. In the federal government, we hope, will be more likely to give the green light to these community paramedicine reimbursement models. But the last point I'll make before I turn it back to Steve here is that you're going to want to make sure that you get your legal counsel involved in helping to structure these arrangements so that they avoid any of these potential anti-kickback issues. So with that, I'm going to turn it over to Steve, and he's going to take us to the conclusion here, and he's going to start by pointing out some of the specific examples of community paramedicine programs. Steve?
Okay, thanks, Doug. There's a lot of good models out there. There's several in particular that we just want to mention, but there's many more that we won't be able to mention, but wanted to give you a flavor for what's happening. In MedStar down in Texas, they implemented a community paramedicine program that really focused not just on keeping people from going back into the hospital, but also on how to reduce some of the frequent flyers that we see out there, as you know. Those who suffer from the Samsonite syndrome, standing out at the curb with their bag in their hand, ready to go, just like a taxi picking them up. And they were able to greatly reduce a number of those transports, and they found that a small percentage of patients were actually consuming a high percentage of the services. Imagine that. So they basically implemented this program a couple years ago, and it's worked very well. Home visits are provided, giving medical assistance to ensure things like medication compliance, follow-up with the primary care physician. It's really improved the patient experience and care and has dramatically reduced ambulance transport costs for the MedStar program, which is a very, very big operation. And Matt Zavadsky, a good friend of ours, has been more than willing to share information about the program, and he speaks around the country on it as well, and his contact information is on the screen and in the handout. And in a more rural area, we have Colorado, we have Eagle County, our friends there, Fred Morrison and Chris Montero and the folks there have done a great job, and Ann Montero as well, in putting together a program that's a pilot program. It involves patients being referred to EMS by their primary care physician to receive certain home services. And they've seen a significant increase in savings. There's a pilot program that hopefully at the end of this program the state will adopt it, and right now it's funded by grant money, and ultimately it's a test case for Colorado and other states as well. And Chris's contact information is there on the screen and in the handouts as well. And the Pittsburgh area, we have the Connect Community Paramedicine pilot program. It's funded by Highmark and University of Pittsburgh Medical Center, and patients there are given a non-emergency number to call as an alternative to calling 911, and paramedics may treat the patient at the home, or they may then decide to transport the patient. And that program is funded by a significant grant from Highmark and UPMC, and of course working directly with the healthcare system there. The EMS entities can certainly partner and see where there are mutual benefits. Doug had mentioned Minnesota. That certainly is where the legislative effort has really taken hold in terms of having an actual certification program and a training program for the EMT community paramedic. That's the new designation, and that's an important aspect of all this, is making sure that you are functioning within your scope of practice and that your state law is flexible enough so that you're able to do these sorts of things, hopefully with local medical director control. So those are just 3 or 4 of the programs that are out there that have been successful. And just sort of to recap, you know, why we need to be involved in these things is we are out there in the community as healthcare gets pushed out of the 4 walls of the hospital into being community-based. We're already out there. We provide the services 24/7. We're community-based. Oftentimes the leadership of our organization comes from within the community as nonprofit organizations or public agencies. We're mobile. We got the vehicles. We're highly reliable. We focus on doing things by protocols and guidelines, which a lot of community paramedicine is all about. And we have the training and experience. These are the points that Dr. Greg Margolis mentioned at the Pinnacle Conference a couple years ago. So very excellent points, well worth repeating. And when you think about it, you need to look to see, you know, have you developed practical and useful key performance indicators? Do you measure things more than good old response time? You know, that's certainly important to measure, but it really doesn't measure the outcome of the patient. Do you measure the compliance things like crew documentation, signature compliance, making sure that you're not leaving money on the table that you're legally entitled to, and on the same token that you're not keeping money that you're not legally entitled to keep. So that's important as well, and quality of care and treatment protocols and all those things. So bottom line, are you truly ready for the buzz of the evidence-based healthcare system that goes hand in hand with healthcare reform? And that's an area that certainly we can all agree, I think, that we've been lacking, and that is being able to prove that we actually make a difference. We pretty much know we do. We have many examples of that, but we got to have the evidence to back up those statements, and that's going to, if we can provide that evidence, that's going to help us bode well as we move into the future with healthcare reform. The other thing is to look at other revenue sources. You know, partnering with your hospitals, your health plans, your community to do a wide range of things, and you know, trying to think outside of the box and looking outside of just the old transportation model, and making sure you're positioned as a voice in your community so that you can deal more effectively with these new competitive forces. So kind of to wrap up the concepts that we're talking about here before we get into some questions, we've got certainly this whole traditional model of the only way you get reimbursed is if you transport somebody is shrinking. It's shifting to a more comprehensive mobile integrated healthcare approach. And the Affordable Care Act does have a lot of opportunities there for us to take advantage as this shifting sea of healthcare begins to take effect. And certainly we're going to have obligations as employers that we have to deal with. The bottom line from a positive standpoint is we expect to see more insured patients, more Medicaid patients. Now, Medicaid may not be the best reimbursement, but getting something is better than getting nothing. And you know, there's going to be an increase there. Hopefully we're going to get more insured patients once they get that healthcare sign-up website ready to go here and get it fixed. You know, that's the whole intent, is to see more people, especially younger people, insured than we've seen in the past. And there are pretty substantial subsidies for people to sign up and to help them pay for their health care as well. So lots of opportunities out there. Doug talked about the preventable readmission program. That's a big one right there because that affects hospitals' bottom line. So that is going to cause them to want to talk to you. Accountable care organizations, you're going to have to take some initiative there and pony up to the table, if you will, and be heard. And in community paramedicine, which can not just help the hospitals in dealing with compliance and improper readmissions, but it can help you in the sense that you can reduce some of the costs you incur with all of these folks that are calling an ambulance when they don't need it. And we certainly have seen an increase of that in the last couple of years. Nobody, I think, would disagree with that. So it's all about prevention, preparation, and getting ready for many of these changes. A couple last announcements before we move into the questions. You can find us on Facebook. Heck, you can find everybody on Facebook these days, including us. So take a look, and we're out there. You could also sign up for our free EMS Law Bulletins at pwwemslaw.com. Many of you subscribe to those already. And we give a lot of timely information, breaking news, frequent bulletins that go out to help you keep you up to speed as to what's happening in our industry to help you deal with some of these impending changes. And yes, our HIPAA guide, the Ambulance Service Guide to HIPAA Compliance, 4th edition. Hard to believe it's the 4th edition. Totally rewritten, totally revised, new forms, new policies, a really slick automatic policy generation feature that is now available for you to purchase if you're interested in that, along with our HIPAA TV video that goes along hand in hand with that program. We also have our 2nd edition of the Ambulance Billing and Coding Desktop Reference Guide. That's been a real handy tool for those of you involved in the billing process. And we got 2 new products we're really excited about. We have the Facility Contracting Kit, and these come from your request. This is a complete package dealing with your whole relationship with medical facilities, model facility contracts for SNFs, hospitals, hospices, a cost analysis tool to help you analyze your actual costs, your total costs, so that you can help keep you out of trouble with the anti-kickback statute. Tools for educating your facilities as to why you have to charge the rates you do. That's a constant challenge. And a whole discussion of pricing compliance strategies. So that's available, as well as the social media survival kit for EMS, which after many months we put together a comprehensive sample social networking policy, a training program that's part of this whole package with approval for CEU credit and a detailed explanation of the law and your rights in this very, very evolving area that's creating a lot of HR problems for EMS agencies and fire departments out there. We've been dealing with a lot of issues related to employee and volunteer use of social media. So if you do have issues in that area, certainly give us a call. And in the spring, we've had our all-time record-breaking ABC3 conference, the largest ambulance reimbursement conference in the nation, here at Hershey just a few weeks ago. We're still recovering from that, but we do have another series of 3 ABC3 programs in the spring. These are the dates. We started off with our Certified Ambulance Coder Live program sponsored by the National Academy of Ambulance Coding, and we also do a one-day intense executive institute to help prepare leaders for all the many changes. Very comprehensive one-day program. We've gotten a lot of rave reviews on that, and then of course our 2-day ABC3, the Ambulance Billing Coding and Compliance Clinic. That's a very comprehensive conference. It's a lot of fun. We try to present information in a way that is usable and that you enjoy being with us for those days. So think about signing up for one of those in Las Vegas, St. Louis, and then Florida at a new resort, the Point of Vedra Beach area outside of Jacksonville, which is a really nice place. So, okay, we do have a few minutes left, and Doug and I are going to peruse over the questions, and then Dan will come on the line too, and if he has any issues or questions he'd like to address, certainly he'll be able to do that. But I noticed...
So it seems that you need to take a deep breath, I think. You guys have blown through a lot of content here real quickly.
Yeah, we did. But do you have one there, or do you want me to start with one?
You know, I will let you start with one, or as you go picking through, you know, we're very happy to have you guys on the line with us doing this session today, and we hope that everybody gets the message that, you know, we've seen lots of things changing in the industry. A lot of things are a little incremental as we started out with the revenue squeeze. You know, there's fear that may continue to happen. So we really want people to start charting their course to figure out how are they going to keep going and be providing the services they need to provide in their communities.
Great. Excellent. And the first question I would just throw out here is that we've got a number of questions asking about calculating the 30-hour full-time equivalent through that formula in terms of determining whether you have 50 employees. And I will tell you this, I'm sitting here looking at a document put out in the Federal Register that is in excess of, you know, 40, 50 pages here dealing with this issue. It's a proposed rule, and we hesitated to get into providing, you know, detail about the formulas and calculating that 30 hours. People are asking, well, you know, do you count it, you know, once a month, or how often do you do this and all? There's no sense in getting into the formulas right now because those are proposed. What you need, your take-home needs to be is that you may have a small number of full-time employees, okay, that are less than 50. But if you've got a bunch of part-timers, that might bump you up over the 50 when you use the calculation of 30 hours per week as a full-time equivalent. That's what you need to at least understand that. So don't go home and think, oh, yeah, I only got, you know, 32 full-timers, so I'm not covered because I don't have 50. The part-timers are going to be calculated in. Now, with respect to the volunteers, someone said, well, are volunteers covered or aren't they? The answer is no, they're not right now. But there's this proposed, you know, guidance from the IRS that goes to this common law definition of employee, which would mean paying or not paying doesn't matter. So volunteers could be covered if that were to get finalized. Now, I believe that there'll probably be a lot of pressure to bear on the administration to clarify this. And certainly this is why the volunteer fire and EMS service needs to speak out and say, hey, wait a minute, there was never any intention to include volunteers in this whole employer mandate. So that covered about 5 or 6 questions in one swoop.
I'll grab one. There's some, Dan, I don't know if you're unmuted or something. I'm hearing a lot of keyboard typing, but this is summarizing a couple of different questions that we got about would doing community paramedicine expand our liability? Would we have more fear of lawsuits and that sort of thing? You know, we've gotten that question a lot, I guess, probably because we're lawyers, and you know, we're the kinds of lawyers, I guess, who don't like to see when our clients get kind of paralyzed by legal fear and then don't do things that are good for their organizations or good for their community. There is not an epidemic of community paramedicine liability. Now, of course, this is such a new thing that if there was, the cases would still be so new that they would probably still be going on. So it's going to be some period of years before any of these cases go up through the court system if there are cases, and until they're decided, and then they go up to appeals courts, and we have written decisions from judges that talk about this. But here's a couple of things. First, again, don't be paralyzed by the fear of legal liability, and I think that concern is usually a bit overstated. Secondly, community paramedicine programs, just like any other kinds of technology that we use or any other new drugs that we use or new devices, it's something that we do after we're appropriately trained. We put it into our protocols. Community paramedicine is the same thing. You can't just kick somebody out into the community and expect they're going to be able to provide primary care. These folks have to be trained. Medical directors need to sign off on their competency to go out and provide these skills. So you've got to make sure you lay the foundation. That's first and foremost. Secondly, look at the laws in your state. What does your state EMS Act say about the immunity provisions that protect EMTs and paramedics in your state? Those might already be broad enough to encompass going out and doing community paramedicine. If they're not, then you're going to have to look at expanding that liability, working with your state elected officials. The third thing you can do is look at your insurance policies. Many insurance policies are written broadly enough to cover those activities already. If your policy isn't, and the devil's in the details, we can't sit up here and say every professional liability policy says the same thing. An insurance policy is a contract, so what your contract with your insurance company covers is up to that policy. So look at the language in your policy. If you have questions, talk to your insurance broker or your insurance agent. And many, if not most, of these insurance companies would probably offer riders or policies that you can purchase that would cover these activities if your current one doesn't. So there are things that you can do to minimize those risks of liability, but through training, medical director involvement, protocol and policy development, these are the ways that we manage liability right now. And there's no reason to think we can't manage that liability when your agency expands into community paramedicine. Steve, do you want to take another one?
Yeah, quick one here. Someone made a comment that what will happen to the older generation when the younger generation chooses not to sign up for the health care and is willing to pay the 1% penalty? Well, that's a very good question. Big debate now in society about this because the whole success of this thing is premised on younger people signing up to help support the older folks. We're already seeing announcements today that health insurers are increasing premiums again. And, that's the concern, is that if not enough sign up, that they're willing to take the penalty, because it's not all that big of a penalty, that the cost of premiums for everyone else is going to go up significantly. But we'll see what happens. But that's a very good question.
Okay.
I saw a couple questions listed regarding related to the ACO and billing and what your contractual requirements are for that. And if I, from our other presentations and being at XI, the understanding I have is if you are a participant in an ACO, you still bill your Medicare MAC the same way you do now. You still are required to meet all of the fee-for-service requirements, but the difference being that at the end of the year when the shared savings are evaluated, you can gain an extra piece of revenue, hopefully, if you achieved your shared saving goals. On the other hand, if you didn't achieve your shared savings goals, then you could have some liability. Is that essentially it?
Yeah, that's a good summary, Dan. And the key with ACO participation is, remember, as Steve said, EMS agencies can't form ACOs. We're not eligible to be a party that forms an ACO. So our role in EMS is limited to contracting with ACOs. And this is sort of like saying, well, contracting with a managed care plan or contracting with an insurer. Again, it is not a one-size-fits-all proposition, and even though the ACOs have shared savings models that providers can benefit in and some risk if it's not if those savings aren't achieved, the devil is in the details, and what those savings are and how those thresholds are triggered are all going to be laid out specifically in that ACO contract. So again, it's like saying, what does a health plan contract entail? It entails whatever's in the document. So folks are going to have to be very vigilant. And the problem, if I may, Dan, is that many times when we see these kinds of contracts, whether it's an ACO or a managed care organization or anything else, is that these contracts are not really written to be unique for ambulance services. You'll get some generic ancillary service provider contract or some generic, participating provider contract, and it's got a whole bunch of gobbledygook in it that's not really relevant and may even be sort of counterproductive. So we get a lot of boilerplate agreements that we see from health plans and other agencies that are provided to our clients, and folks really have to look at these carefully, because when you enter into one of these, that's the document that's going to bind you, and that's what a lot of folks don't realize. They think it's just, I'm in an ACO, now it means this, X, Y, and Z. It means whatever your contract says it means, and that's an important point.
Okay, here's one basically asking, is this community paramedicine thing another way to say we're going to get paid extremely low, 30 to 60 bucks to do treatment and no transport services? Well, what I've seen in Minnesota, for example, I believe it's $60 an hour that they're paying. It's something like that. It's like 60, 70, it's right in that range that they're paying for the services. But you could look at it from the standpoint of there's downtime, or there's people you can assign on the shift to do that work that not only is going to get you out in the community, you'll get some money from that. Certainly you're going to pay a paramedic less than 60 bucks an hour, so presumably you'll be able to make a little bit off of that. But it's not going to be a huge money maker with direct reimbursement. It's going to be more of a money maker in the sense it's going to reduce overutilization and unnecessary calls and so forth. So that's an important aspect of it. And then somebody asked about if you're not a delegated practice state, and a lot of states are, meaning physicians can delegate certain aspects of healthcare for their patients to other physician extenders who do not even need to be certified in some cases. But if you're not a delegated practice state, how do you get around the home health care agency laws requiring first visits to discharge patients by RNs? We also call those the Registered Nurse Preservation Acts of each state. And there's a lot of those out there, and yes, those need to be looked at. Doug mentioned this. You got to get to your legislators to say, hey, these antiquated rules that, paramedics can't work in ERs and paramedics can't do this, can't do that, those need to be changed. Healthcare has changed from 30 years ago or 20 years ago. Folks, here's a big problem with healthcare reform. All this stuff is happening. We haven't even mentioned the significant shortage of thousands of primary care physicians that we're going to see in the next 5 to 10 years as a result of the baby boomer generation going out there and getting old, and we're all retiring and going to need health care. There's not a whole lot of incentive there for people to go become a primary care physician. They're going to be needing physician assistants, certified nurse extenders, whatever, community paramedics, all these other types of certified folks who are less than the level of physician are going to really be expanded in the coming years to help meet that need. So that's a real great opportunity for us, I think. Okay.
Well, very good. I want to thank both Steve Worth and Doug Wolfberg for joining us today on this webinar. We've run a bit over so we can get some questions answered, and appreciate everybody for joining us on this webinar today. As always, we welcome your feedback and suggestions for other topics that you'd like to hear. You can email webinars at tritech.com. Any parting comments from either Doug or Steve?
No, just thanks for having us. We've enjoyed it a lot, and it's always fun working with you folks at TriTech.
We appreciate it, and we'll talk to you again later.